Hi, my name is Devin Sherman, and you're listening to Health Talks from the Inside Out.
Dr. Devin Sherman, one of our pulmonologists and a critical care physician here at Williamson Health, sitting down with us today. Thank you for being here.
Michelle, great to be here. Super excited about doing this.
Thank you. So let's just kind of start at the beginning. What drew you to medicine and then eventually to pulmonology?
Good question. My dad was a family doctor, and I live in a small town in northwest Tennessee, Union City, Tennessee, for all the Westies out there.
Okay.
And I grew up watching him be a doctor and really saw the respect that he had of his patients and the community, and it really struck me as something that would be a great vocation, not just a profession or a job. And so I kind of went off to college and knew pretty quickly that's where I wanted to go. But I also had, when I was at college, I also wanted to just explore the world a little bit more. So I also did like philosophy and sociology and other sorts of, thought-provoking disciplines, just so I could have a broader sense of things when I went off to pursue medicine.
Yeah, I love that. And so eventually pulmonology, or even critical care medicine. How did you find your specialty?
I think different people come at this differently. I would say different specialties in medicine have different personalities.
Okay.
And I think you can say, well, I was drawn to the science or the different disease processors, but I think a lot of it has to do with the people you were around and the experiences you have and who influenced you. And I had wonderful experiences, pulmonary medicine, particular intensive care medicine. My father-in-law is a pulmonologist, and so there were some things that drew me to that that made it real clear that was what I wanted to pursue.
Okay. So can you break down maybe each of those for us? Like, what is pulmonary medicine and intensive care medicine? What are the differences, similarities?
So pulmonary medicine is obviously the respiratory system and different diseases that relate to that. Critical care medicine actually grew out of pulmonary medicine because back in the 70s, and this was in Denver, at Jewish Hospital in Denver, they started trying to figure out, how do we take care of these critically ill patients that are, kind of getting the end stage of their lives. There's not much else we can do for them. And a lot of what was causing that end stage of disease was respiratory related problems. And so that's when they started coming up with things like ventilators and additional respiratory support and that sort of thing. And so that's how pulmonary and intensive care medicine became intertwined. So you've got lung disease, pulmonary medicine, all the diseases with that, and then intensive care medicines, when things get really bad, the body is starting to shut down and needs a lot of extra support. And so that's a place, usually in the hospital, where all of those extra support systems are put in place. There's more nursing support, more observation, careful, intensive monitoring treatment, so you can try to get through those terrible situations.
Okay. One thing I was thinking about is I knew I was going to be sitting down with you today. What do you think is the most interesting thing about our lungs?
So I talk to patients about this all the time. The lungs are the largest part of our body that's open to the outside world. And we think, well, wait a minute, that's our skin, right?
Right.
That's what's exposed to the world. But no, that's actually the third. The second most exposed part of our body is our GI tract. We think about, from our mouth all the way through.
Right.
But the lungs are by far the largest. And so if you were to take all those little tiny air sacs and spread them out in the surface area, it's the size of a tennis court, packed inside of our chest.
Wow.
Yeah, isn't that incredible?
I have never heard it described like that.
So there's that part of it, but then the other part of it is, so you've got this huge part of our body that's exposed to the world, and we're breathing in. Just think of all the stuff you're breathing in all day long. Dust, particles, viruses, fungus, molds, all this stuff that's going right into our bodies. And the air sacs are 1 to 2 cell layers away from our bloodstream. And so that's why the lungs end up being this really cool organ, because you've got this really sophisticated immune system that sits right in the middle of your body, protecting you from the outside world. And that's why so much happens inside of our lungs and our body with illness. And so again, getting back to why did you pick pulmonary medicine? That's one of the reasons. I think it's a fascinating part of our body.
Yeah, I love that. You said they're the protectors.
It is.
From the outside
absolutely,
world. That's
yeah.
pretty cool. I was going to also say what is the most surprising thing, but that might
That's
be
it.
It's the most interesting and the most surprising thing about our lungs.
Yeah, and I also think about the idea of breathing. I think breathing is the one thing that our body does that is, it feels like it's almost the most that we're most in tune with. That's why things like meditation and breathing exercises and things used to calm ourselves down, or when we get anxious, we have trouble breathing. It's just part of how we are and function through the day. And I also find that very interesting to talk to patients about and see how they're perceiving that and feeling those things. The idea that we can control our breathing, you know, is a vital function of our body is really different too. We can't control our heartbeat. We can't control so much of our other bodily functions, but we can be aware of and control our breathing. So I think that's another really interesting part of the respiratory system.
Wow. Anything else that we should know that I'm not even thinking to ask?
Oh goodness.
Just as we start about the lungs, yeah.
No, I think that's it.
Okay,
That's all you need to know.
That's it. We got it. Okay, well, let's dive a little bit deeper into what are some of maybe the conditions of the lung and lung disease, some of the common things you see in patients.
Great question. So there's the big ones, and so a lot of things that we see are asthma. So asthma is a really common disease. It affects kids from birth to through their whole lives, and there's probably 40 million people with that diagnosis in the U.S.
Wow,
So it's a fairly common disease state, and that's usually inflammation of the airways and sensitivity to things like allergies and other things in the air and environment. Emphysema or COPD is the other real common one that people are aware of, and that's usually from smoking. But you can get COPD from other reasons. The most common cause of COPD in the world is not from cigarette smoking. It's from being in indoor enclosed homes where cooking and those sort of things are happening. And that ultimately leads to the most common reasons for COPD worldwide. But in the US, it's smoking. And then of course things like lung cancer. Lung cancer is a complication of smoking usually, but increasingly not. Pneumonias, those sort of things, lung scarring and fibrosis. Those are the main big things that we see in the pulmonary clinic.
Yeah, I'm sitting here thinking more recently we're hearing about vaping, especially maybe among the younger generations. I assume that is also leading to some lung disease and issues.
It leads to two things. One is a lot of uncertainty. So like we talked about, the lungs being such a sensitive organ, you got to do everything you can to protect them. And so inhaling anything that's really not supposed to be there, probably not the best idea. We don't know the long-term consequences of vaping so much. We know that there are certain chemicals and additives and flavorings and those sort of things that are having immediate effects to the lung, but what do they do after 20 years or 30 years or 40 years? We just don't know. The other thing we worry about vaping is it's a little bit of a gateway. And so you have maybe a 12-year-old or a 13-year-old, sure, they're not picking up the cigarettes like they did when I was in 6th and 7th grade, the kids running behind the band house, but they're vaping and then they're getting addicted to nicotine, and then it's what's next? Are they going to become smoking, or is that going to become more popular? And that's we've actually done a great job over the last few decades of reducing rates of smoking in the population. You'd hate to see that go the other way.
Absolutely. So with these common lung or respiratory conditions that you see, what are some of the symptoms that first present in patients?
So I would say the most common thing is the shortness of breath symptom. Now, all of us can get short breath. And whenever we do things, we get short of breath. And that sort of process is not atypical, but when somebody notices that that's happening much more frequently, sooner than they would expect, that's something that's going to take some notice. With that, that's why I always tell people exercise is great for a lot of reasons, but when people exercise routinely, it's almost like they're keeping a check on that themselves. They've got a good sense of, here's where my breathing is, here's what I can do before I get short of breath, and when that starts to falter, they've got a better sense of when that happens. So another plug for exercise if there's not enough already. Coughing can be another common one. Again, these are things that happen. We all get cough, but cough kind of comes and goes. Usually it's something that after you get sick or you're exposed to something, maybe a couple of weeks,
Right.
that sort of thing. But if it keeps dragging on and on, that's something we need to worry about.
Okay.
Any type of wheezing or tightness in the chest and those sort of things are always abnormal. So that would be something always to say, what, something is not going right with my lungs. I probably need to get this looked at.
Okay. And so when patients do find their way to your office to see you or one of your colleagues, what are the different treatment options that we have available?
Good question. And it really depends on which of those types of illnesses you've got. Once you go through a thorough evaluation and we have a good delineation of, okay, here's where we think your problems are. Most of the medicines that we use in the pulmonary clinic are inhaler based, right? We're trying to deliver medicines to the lungs themselves. And that's a really good thing because we're hopefully mostly delivering local therapies just to the lungs themselves. A lot of medicines that we have to give for other conditions, we have to take as pills or injections. That tends to get in the body, have more side effects, and so we're able to target things a little bit better. There are other types of disease states that we may look into other modifying therapies that are going to reduce risks of flare-ups or progression of those diseases, but it's really dependent on the disease itself.
Okay. Are there exercises? Are there there's physical therapy and some other specialties and medicines. Is there physical therapy?
So there's a couple things.
Okay.
Yes is a short answer. Exercise in general is the best one.
Okay.
And so when I have this question come up quite a bit, it's like, well, is there anything I can do to make my lungs work better?
Right.
And yes, there are some things you can get that are, resistance breathing exercises, those sort of things. But the data doesn't really support those. Make a big difference in most respiratory diseases, but routine exercise does. And that really comes at the idea that you've got people that have a lot of, difficulty breathing. They are having shortness of breath. Maybe their lungs are impaired. We can sometimes make that better with medicine. Sometimes you can't make it a lot better. But what you can make better is the rest of the body. And that's where routine exercise comes in. You can make the heart stronger. You can make the muscles more efficient. You can make all that work together better. Sometimes people with advanced lung disease can't do that very well on their own. You can say, okay, go exercise. And the problem is people will either not do very much because it's hard and they get real short of breath quickly. So they just kind of don't do much and probably didn't help them that much. Or they say, okay, I'm going. And they really try to do a lot and they very quickly fall apart and they can't keep going and they get very winded. We have a dedicated program to help people in that situation called pulmonary rehab. So that's a 6-8 week program that you go through. You meet with exercise therapists that put you on a regimen that really helps you walk that fine line so that you can do enough exercise to make improvements and get better. And so that you really learn how to do that. And it's great because you finish it, you feel better, and then you know how to keep doing it on your own after you finish. So it's a really great program. If you've got advanced lung disease, I highly recommend it. The folks at our Williamson Hospital here are excellent, for sure.
Good to know. Okay. And I would assume a lot of the patients and the conditions that we're talking about are chronic. It's something that patients are dealing with for at least a long period of time, if not their whole lives. So can you talk a little bit about the importance of the collaboration, I guess, between you and the patient, but then maybe also their primary care? Is that physician brought in sometimes as well?
Absolutely, because having a lung problem is it does impact your entire body, and a lot of these are chronic issues, and there are things that go along with that. When you're inactive, when you can't get out of the house, when you can't do things that you would like to do, you have to worry about other disease states, and so those things can include heart disease, they can include osteoporosis, depression, anxiety. Those are a lot of times things that are, from a global health standpoint, we have to really be thinking about for our people to live full and as productive lives despite having limitations related to their lungs. And so great relationships with your specialist providers, your primary care providers, your family, and churches and other community organizations or disease specific support groups can be really great for people to kind of find commonality and a way to deal with such a situation that impacts their life.
Okay, so with November being Lung Cancer Awareness Month, let's talk a little bit about lung cancer.
Mm-hmm.
So how do we detect lung cancer in patients, and then maybe what happens after that?
It's a great question, and lung cancer is an awful disease.
Mm-hmm.
And one of the reasons it's such an awful disease is it is really hard to detect.
Okay.
Lung cancer can become quite advanced without really having many symptoms. And so that makes it a really difficult scenario to sort out for patients. Oftentimes, lung cancer is detected incidentally.
Okay.
And so people will go for other reasons. They'll get a chest x-ray, they'll get a CT scan of their abdomen or their chest or some other imaging for some other reason, and then there it is.
Yeah.
We see it.
A mass. Yeah.
That's right. So I would say that's probably still the most common reason we're finding lung cancers. However, as of about, I'd say 10 years ago at this point, there's now recommendations for dedicated screening. And so we try to identify people that are at the highest risk. And those typically are smokers of a certain age, usually between the ages of 50 to 75, that are still smoking or have quit within the previous 15 years. And we're trying to find those groups of folks that are at that highest risk and then screen them proactively with CT scans of their chest once a year, so that we can detect these lung cancers earlier, because with any cancer, but particularly with lung cancer, the earlier you find it, the better.
The better. And is it correct that often in those cases of smokers or heavy smokers from the past, insurance will sometimes pay for those annual screenings?
Absolutely.
Okay.
So the current way this works is that it's considered a screening test like all others, and screening tests are covered.
Right.
And so mammography, colonoscopy, screening pap smears, and low-dose lung cancer screening are all kind of lumped into that group together, and are covered by the U.S. Preventive Task Force.
Yeah, for those high-risk patients.
For those high-risk patients.
So let's talk about the opportunity that we're offering to patients this month. We're offering that same screening, that low-dose CT scan, to anybody, whether they're at risk, high risk or not, whether insurance will cover it. They can come in for $150 and just get the scan and find out.
Absolutely. I think that service is an excellent opportunity for the community. Like we said, so many of these lung cancers are found incidentally. And so people know their own body. I think that's one of the things that we try to give people, like these guidelines, and say, okay, here's where what you should do. But sometimes people know how their body feels or what their own story is. And so this is just an opportunity that gives people that option to explore this.
Yeah. And hopefully nothing will be found, and then you have peace of mind knowing there's nothing there. Or if something is there, at least people can have the opportunity to find it earlier. And like you said, there's a much better survival rate and treatment rate if we get it early.
That's right. And so one thing with CAT scans is, we see into the body in these miraculous ways, and we can see anything that is there, but sometimes we see things that aren't anything. And so that's the other part of this is, yes, you may find things like early lung cancer, but you may also see things like what we call lung nodules or other abnormalities in the lung that are not cancer. They're there, we see them, but then you have to say, okay, what do you do with that? And so that's also part of what happens when people go get scans for all kinds of different reasons, is they may find these incidental findings. Then it comes down to kind of sorting through what that is, because the last thing you want to do is, have some sort of finding on a CT scan that leads to a bunch of tests and biopsies and extra things you don't need. You need to have a thoughtful, discussion about, okay, here's what this finding is, here's what it means. It's nothing to worry about, or it absolutely is something to worry about, or it's somewhere in between.
Yeah.
And then how do we work our way through that?
Yeah. And can you talk a little bit about the equipment and the technology we have in our lung nodule clinic to determine what some of these nodules are?
Yeah, that's a great question. So one of the great things we have is a Julie Brown. And so she's our lung nodule navigator, coordinator. And because there's so many of these patients out there that are having these findings and sorting through, and then if you do have something that's concerning and could be a lung cancer, boy, that's scary. And you need support, and you need to work through that process as efficiently and expeditiously as possible. And so That's what Julie Brown helps us do. And so
Yeah.
she's phenomenal with that. From the technology side, we have what's called navigation bronchoscopy and endobronchial ultrasound. Those are all technical sort of
Yes,
stuff.
don't make me say them.
I know, right? So the navigation bronchoscopy is really cool technology. It's probably been out for 15 years or so, and it creates your roadmap, or like almost using GPS for your airways and lungs. And so it lets us go way out into the lungs and find little areas, a centimeter, the size of a pea, and get right up next to it and put needles inside of it. The idea that we would have been able to do that 20 years ago, no way. And so that is rapidly improved, and we've had a lot of great success with getting better and better in some of those diagnostics into the lung. The endobronchial ultrasound is an ultrasound on a scope that goes down into the airways that we can find lymph nodes that are living there and take biopsies of those. So it helps us diagnose these lung nodules if they're lung cancer, and then stage, in other words, find out where it may have spread in the lung, and get that kind of full picture of what's going on. So we're able to access a lot of the body that we weren't able to a while ago, and have great equipment here.
Yeah, what a blessing.
It is, for sure.
And you mentioned our lung navigator, and we've recently talked about our breast health navigators too, because they have something similar in that clinic. And it's just so wonderful to have an actual person that is walking with each patient through whatever their process and their journey ends up being. So I know that's a tremendous blessing for so many
It
patients.
is. I mean, I've never had to be in the same shoes that I've had to talk with and walk my patients through, but boy, you just need somebody to be there and somebody to listen and know that somebody's got you.
Yeah.
Because you can feel really left out there if you don't have that. And so if you've got somebody that's an anchor that you can call at any point to help work your way through that, it just makes a tremendous amount of difference to feel comfortable. And so many of our patients have had a great experience like that.
That's great. So let's talk a little bit about the actual scan, because we say it's a low dose CT scan. So, and I know it's pretty quick, you're kind of in and out, but can you talk about the process, like how long it takes, and then what does that low dose part mean?
What does that mean? That's a good question. So low dose part of it, we'll start with that one. So one of the concerns people have about getting any kind of imaging is radiation, right? So you say, oh, you're giving me another scan, I'm going to get another scan once a year. What's that going to do to my body with radiation? So when this question comes up, I try to frame it for folks. And so we start with a chest x-ray. So a chest x-ray is just a quick little snapshot that we use a single dose of radiation. And that's about the equivalent dose of radiation of spending one afternoon in the sun.
Okay.
So just to kind of get a sense of, okay, what does that mean for me?
Yeah.
A full CT scan of the chest, kind of a diagnostic one that you would get to look for problems, or from the emergency department if they're looking for other things. That's about 250 chest x-rays worth of radiation at one time.
Okay.
A low dose scan, what we're trying to do is we're trying to get enough information, delivering enough radiation into the body to get good pictures, kind of without overdoing it.
Okay.
We're not trying to see every little thing in such detail, but enough to say, okay, we can find nodules, we can do that. So that ends up being about 100 chest x-rays worth of radiation.
Okay.
So it's not, not a freebie,
Right.
but it's not like you're getting blasted either. And so we're just trying to get that nice balance of getting good enough imaging without overdoing it.
Right. And there's enough research now that, yes, while there might be low amounts of risk with any kind of test like that, the risk of having that done outweighs not knowing if there's something there.
Correct, yeah. Risk and benefit. And risk and benefit, I tell people everything we do is risk and benefit, right? Deciding to drive to the grocery store or whatever it is. Yes, that analysis, that weight back and forth certainly leans towards, if you're in that risk profile and you're somebody that if we could catch lung cancer early with one of these scans and you're doing it every year, we reduce your risk of dying from lung cancer by about 30%.
Yeah.
So that's worthwhile.
Yeah, absolutely. So for community members who want to participate in this special screening opportunity this month, they just have to call in by November 30th, and then they can get scheduled. We're offering it at 2 different locations. Our Williamson Health Outpatient Imaging Center is one location, or they can come to the Bone and Joint main campus. We've already said it's $150 self-pay. Insurance will not be involved. And how can they call?
This is for my 14-year-old.
Yeah.
We're going to drop it in the chat, and you can
Love it.
find it on the socials.
Yes, we're going to be promoting it a lot.
Perfect.
I also have heard that for Giving Tuesday this year, which I believe is on December 2nd and is celebrated nationally, our foundation, the Williamson Health Foundation, is raising funds to get y'all a new piece of equipment in the lung nodule clinic. Can you talk a little bit about that?
Yeah, so from what I understand, there's a push to try to help raise some money for one of our vital pieces of equipment called a bronchoscope, and so that's the main instrument we use to go down into people's lungs, and so that's an opportunity to really have community engagement in a way that lets us continue to take great care of the community in this very important way.
Yeah, and so we have one currently, but this would be an effort to get a second one, so that would be a great,
That's right. So the one that we have is being is no longer going to be serviced, and so it's going to be shelved, and
Great.
so in order to have an active one, we need to update as always.
Yeah, so that does sound like it's a great way the community could get involved and give back via our foundation if they wanted to. Okay, so what about people out there who might be experiencing some mild respiratory symptoms, but they haven't really done anything about it? What do you recommend they do?
Well, I think anybody that's got a concern about how their body's feeling could have it explored, and so there are some very straightforward ways to just get an assessment of how things are going, and that's usually going to start with your primary care doctor, because they're going to be your front line to say, okay, there's something that's not quite lining up here, something doesn't seem right, or no, I think everything's okay, and give you that reassurance. Some simple tests might include like a chest x-ray, an assessment of your oxygen level with an oximeter, and then of course a discussion of how you're feeling and what types of symptoms you're having, and then how do your lungs sound on your exam. So those basic sort of things will help kind of determine, okay, this is something that's pretty well in line with how things should be, and let's watch it, or no, we need to get this investigated further.
Okay, so primary care is generally the first line where somebody will take this, and
Generally
then they will
so.
refer in to you.
That's right.
Okay, so what would you say is the most rewarding part of your job?
I really love the relationships I have with my patients, and I've been doing this now for 15 years, and so some of them have been my partners for 15 years, and what I really enjoy is, we talk about their lungs and their medicines and their health, but boy, we really get to just learn about each other, and I really feel like those are the most rewarding experiences when you have a real comfort with the people that you work with, and can really enjoy getting to know them and helping them as best you can, because as we talked about, sometimes people, advanced lung disease is not that fixable. It's really just a chronic problem, but that doesn't mean you can't be there for people and help them and be supportive, and that's really rewarding.
Yeah, I love that. So without obviously giving any personal details, is there a patient that sticks out from over the years, somebody that you were able to really make a difference for?
Yeah, there's a few examples of folks that have been in really tough situations where they've had really bad illness, ended up in the hospital, and gotten to a point where may not make it.
Right.
And a lot of times the recovery from those episodes can be long and arduous, and it sometimes feel like I'm never going to get back to any sort of meaningful recovery here. But there is one patient in particular that got to a point where he was really frustrated. We kept working our way through it, and he did, with dedication, and this really almost always comes down to them. Hard work, kept at it and kept trying to get better, and got to a point where he was able to start biking and doing, really more increased exercise in a way that he just never, even before he got sick that way, never thought he would be able to do. And I think that sort of journey, when you've got somebody that's willing to put in that sort of effort for their health, really rings positively.
Yeah, that's great. Is there one thing you really want people to know about our lung health?
Yeah. I think, like we talked about, exercise is by far the most important intervention that you can possibly do for your body, and that's not just the lungs, it's everything. I look at, talk to patients all about, we can try this medicine, we can do this test, we can do these things, but if you looked in that supply closet of medicines that we've got next to our office, every one of those medicines basically can be replaced with exercise. And it's amazing how resilient the body is when you challenge it and push it and can put in the effort to do it. And so anything and everything we do, make sure we're including that as part of our health journey.
That's great. Okay, you've inspired me. I need to get out there and
Me
exercise
too.
more. Well, good. Well, thank you so much for being here with me today. This has been wonderful, and I think we've shared a lot of great information.
I appreciate it, and thanks again for having me over, Michelle.
Yeah, of course.